עד מתי המפגש, חברים?
5:30.
אני בניו יורק, אז כמה זמן זה? שעה וחצי?
2 שעתיים.
שעתיים, יופי, מעולה. הראשון היה מדהים, מאוד נהניתי, תודה לכם. תוציאו הקלטה של המפגש אחר כך, סליחה.
כן.
תודה, כי אני צריך לראות מטופלים אחר כך, ביי.
All right, it's 8:35, so we'll go ahead and kick off the program. Again, I want to just welcome everyone that came, our colleagues from the United States, our colleagues from Israel that gathered today to talk about a topic that I'm sure that everyone on this in this symposium is passionate about, which is telehealth. And so just a couple quick guidelines. We'd love for everyone to, we love seeing faces, so we'd love you to keep your videos on if possible, and try to keep the mics muted during the presentations. That way our presenters could present. After the presentations are over, we're going to have about 5 minutes for questions afterwards. And during that time period, you could enter questions into the chat, enter any comments into the chat, and the two moderators, myself and Ron, will go through those chat questions. If the question's very complex, then we could unmute you to go over it, but we would love to have audience engagement as much as possible. Just a brief overview of the run of show today. So my name's Chad Illy-Moodle. I'm the director of the Institute for Healthcare Policy and Innovation's Telehealth Research Incubator Lab. So I'll give a brief introduction to IHPI and the work that we're doing in telehealth, including an example of one of the studies that we're doing in our research lab. Then I'll turn it over to my colleague Esti, who will give an introduction to the Israel telemedicine community. And then we'll start our wonderful presentations today that we have. We have 5 presenters who will present on various topics from the US and from Israel. And the presentations will be moderated, or question and answer sessions rather, will be moderated by myself. And then also Dr. Ron Berent, who's head of pediatrics work group at the Schneider Children's Medical Center. So just a quick brief introduction to, we have University of Michigan, and then within University of Michigan, there's this Institute for Healthcare Policy and Innovation. And so the Institute for Healthcare Policy and Innovation is a collaborative of 677 like-minded researchers who like studying the common thing of improving quality, safety, and equity and affordability in healthcare. And so these members come from all across the campus, multidisciplinary, to study these topics through research. Within the Institute for Healthcare Policy and Innovation, we have the Telehealth Research and Innovation Strategic Initiative. And so the IHPI has several strategic initiatives or areas of focus. And the telehealth has been an area of focus for the Institute for Healthcare Policy and Innovation for many years. And there's many researchers among the 677 that are studying telehealth. And then within that particular strategic initiative is our research lab called the Telehealth Research Incubator. And our single focus is to help understand the population level impact of telehealth to help inform United States national healthcare policy. So we study population level spread of telehealth and how that's affecting access, quality, costs, and also the user experience. And so I thought it'd be nice to just kind of give a brief overview of telehealth in the United States so that all of our colleagues are kind of on the same page in terms of how telehealth has grown in the United States. Telehealth has actually been around in the US for decades, but it's barely been used. Before February of 2020, less than 1% of healthcare that was delivered in the United States was delivered through telehealth. But the Medicare program, which is the largest insurance company in the United States, or the governmental insurance company in the United States, began reimbursing physicians for telehealth back in 2001. So it's been around for a very long time, but it was restricted to patients that were in rural areas. And there was also a regulation around it called the originating site requirement. And what that meant was that not only did you have to be in a rural area, but you couldn't connect from home either. So you had to travel to a medical facility in order to connect. And because of this tight regulation, less than 1% of healthcare being delivered as of February of 2020 was through telehealth. But then in March 2020, when the pandemic started in the United States, many major regulations were removed by the governmental insurance organizations like Medicare, but then also our private insurance organizations as well too. Patients were allowed to connect from home, whether they're in a rural area or in an urban area. Physicians were reimbursed at the same as if the patient was coming into the office. Healthcare providers could practice across state lines, which was restricted in the United States prior to the pandemic. Patients had their co-payments waived. And then a lot of the privacy rules in the US were relaxed too, so that common technologies could be used to deliver telehealth. And this is what caused telehealth to be widely adopted in the United States, along with the obvious desire for social distancing during this time period. I'm sure you've seen similar trends in Israel, but in the United States, this is a study from our research lab where we use national Medicare data. And this is a 20% sample, but I'm sure the trend is very similar in Israel. We saw from July, on the x-axis here are monthly rates of telehealth use. And from July until February 2020, less than 1%. And then from March to June 2020, we see a peak in the use of telehealth. That's that blue dotted line. The dark black solid line represents in-person care, which dropped significantly during this time period. And then telehealth use has tapered off in the subsequent months. And right now, about 1 in 6 healthcare encounters that are performed by patients in the governmental program are through telehealth. And so for us, there's a lot of state and national issues that will impact how telehealth is delivered after the public health emergency. So the COVID-19 emergency is when all these regulations were relaxed, but what's going to be the final shape and form is still under debate in the US. Removal of the originating site requirements so that only rural patients can do this. I think most people are on board with that. Should we cover audio only telehealth? So if you did a telehealth visit just through the phone without using video, should that be covered? United States law required video before, but should it be allowed afterwards? Should we be allowed to practice across state lines? What should be the payment rates? What's clinically appropriate telehealth? How do we prevent fraud, abuse, and overuse? And then this issue with compliance, the technologies that may not be as secure as other technologies, should those be used? All of these things are still under debate right now. And so I want to just give a quick brief example of the type of population level research that we do in the telehealth research incubator. I'll mention that this is specifically about rural access to care. So prior to March 2020, patients had to be in a medical facility in a rural area to participate. This was relaxed during this public health emergency, or PHE. And so the big policy consideration is, how has telehealth changed access to care in rural areas? So one way of measuring access is just pure utilization. So this is a single state in the United States, Michigan. And what we've looked at is the change of telehealth penetration. On the left-hand side, that map there is rural areas in the state of Michigan, that's colored green, and the non-rural areas are striped. And so in 2019, which is the map that's in the middle, you can see that there were some low levels of penetration of telehealth, mostly in these rural areas. And then in 2020, you can see that things have drastically changed. There was an increase in rural areas, but more importantly, a lot of the urban areas, there was a high density of telehealth visits too. So this is what we see in utilization, but is that really access to care? So our research lab is thinking about access to care a little bit differently. So telehealth may make care more convenient for both urban and rural areas. But if we really want to fix the urban-rural disparity that we have, rural patients must be able to travel outside of those rural areas in order to get care. Otherwise, it's just more convenient care as opposed to providing more care to rural patients. And so to think about this, we designed a study where we thought about geographic units called hospital service areas. So hospital service areas are geographic units or local markets where care is delivered. So a patient that lives in a specific hospital service area can stay local and get either in-person care or telehealth care. That's considered local care, or they can travel outside of that hospital service area and get external care. And so that external care can be in person, or now that external care can be through telehealth. So this was the research design that we used. We wanted to understand the trends in local care, and then also the trends in rural patients moving outside of their areas to get care. And this is the data that we see here. On the x-axis are the months. And so again, these are monthly rates of outpatient visits. The gray area represents local care, and some of that's done through telehealth. But again, that local care that's through telehealth is just more convenient care. And then the blue area represents external care. You can see that the blue area really dominates. So a lot of these rural patients are still traveling outside of their local areas for local markets for healthcare. And then the yellow line represents external care through telehealth. And so telehealth, as of after the pandemic started, did help reduce the amount of travel that was needed for external care. But I think that entire blue area really represents a big area of opportunity for improving rural access to care. Our research findings in this area so far are as telehealth is not just for rural patients. It has improved access to care, but in-person care still dominates. Patients are still traveling outside of their local markets for care. We looked across specialties and also markets, and we saw differences. So that's an example of one of our studies. We're really excited to bring multiple different types of studies forward today to talk about it. John Pate will be talking about artificial intelligence and telemedicine, how to improve chronic care. Naomi Geffen will be talking about pediatric telerehab, some challenges with that particular mode of telehealth. Jennifer Severe will be talking about patients and their initial decisions regarding telepsychiatry. And then Shoshana Yeshayahu will be talking about the first national program in Israel of cardiac rehabilitation to goals, achievements, and adherence and responsiveness. And then finally, Jojana will be talking about telehealth and pediatric care during the COVID-19, specifically talking about parental perspective. So very excited here for these presentations. I'm going to turn this over to my colleague Esti to talk about the Israel telemedicine community.
Thank you very much, Chad. I'm really happy to see that although we know and we are aware to the differences between the US and Israel, so many challenges we have in common. So I'm really happy to see that. I'm Esti Shelley. I'm the head of the digital health department here in the Ministry of Health in Israel. And I'm also honored to be the co-founder of the Israeli telemedicine community, which we founded with members from Maoz and Inbar and from the Israeli Healthcare Society. Later on, we will meet some members and some people from the core team, including Dr. Ron Brandt, who leads the pediatric work group, and Dr. Naomi Geffen, who leads the child healthcare work group, and she will show her research today. But before starting talking about the community, I would like to thank Chad and Emma for their collaboration. We try to reach out and to create bridges and try to learn from other countries and other experts' experience and practices. And we reached Chad, really it was about almost a year ago, and we received like an immediate response. And we're really happy to have this collaboration, and this webinar is just one example of the collaboration that we would like to see further. Ran, can you? Thank you. So the Israeli telemedicine community was established in August 2020, a little bit after the first wave of COVID in Israel. And what we saw on one hand, huge challenge. We saw the numbers that Chad showed, some of the numbers that we saw during April and May 2020. And in Israel, the numbers weren't so different. We reached to the point where about 50% of the meetings between a physician and a patient were virtual. And in Israel, you can be reimbursed also for a phone call visit, but also for video chat. And although that we saw the difference and the huge change, and we had less barriers also in the regulatory side, but not only, we were worried. We were worried how telehealth is being conducted. We thought that we need to act in a very, let's say, smart and more responsible way to make sure to have more smart use in telehealth. And we understood that we, as a government, cannot do this alone. So we worked together with a beautiful and amazing team of several dozens of healthcare leaders, key opinion leaders, that working and running with us for the last 18 months. So our vision, our vision in the community, in the Israeli telemedicine community, is to create a learning system that will drive and move telemedicine practices and will enable the Israeli healthcare system and the patients to benefit from all the opportunities of telemedicine that can offer. The issue that you show, Chad, in your presentation about access to healthcare services in rural areas, this is one of the issues that we are really struggling of even how to measure, and I took some notes of some of the definitions that you show. So in our community today, just to give you a sense, we have about 10 working groups. You can see here the leaders of the 10 working groups that we all really appreciate their efforts and time of being part of the community. We have now more than 1,000 community members, and we are really happy about it. And we are going to open soon a few new working groups. Next slide, please. So our working groups focus on different activities and actually trying to work on the challenges of each discipline in their clinical work. For example, they are writing guidelines for how to provide telemedicine services, like in pediatrics, in the group that Ron is leading, and how to develop new training tools for their teams, and to promote research on topics that they believe that will promote their use in their care. Next slide. So what we see here in this activity is part of the ILTC Research Club, which is a new venture that Ran Milman, who is very quiet today, but he is definitely the brain behind this initiative. We started in order to promote research in the field of telehealth. We believe that if we want to move from speaking about telehealth to become health, or telehealth services to become health services, we need to conduct a better research and better understanding of the use of healthcare services using tele. And we established this ILTC Research Club recently, and we see that there are several hundreds of professional members that you can see, and about half of them are active researchers in the field. Next slide, please. So until today, we had just 2 club meetings. This one is the third, and we really plan to have like once a quarter a meeting for the club. And we also share some funds that are available and offered different opportunities to conduct research in this field. One of them that I would like to share, and hopefully you will see it also available very, very soon, is a collaboration that we done in the Ministry of Health with the Israeli MOH chief scientist, to fund telehealth research. And in 2021, we invested 1 million Israeli shekels. And when I saw, Chad, the numbers of the research fund that you are sharing, that's a difference between $1 billion and $1 million. But this is a start. And currently we are funding in 2021, we funded 12 studies. And soon in the next months, we are going to publish the next call for proposals for the next round of the research fund. Next slide, please. And as I mentioned before, we see this meeting as a very important opportunity to expand the horizons and to learn about research that is being done in both sides of the oceans. We hope that this event will lead to more events and more collaboration between the 2 institutes. And I want to thank Chad again, and also to share with you that Chad was one of the reviewers of some of the studies that were in the research fund. So thank you very much, and I would like to ask Shoshana, will be the first. Shoshana is the first one, or John? Sorry for.
I think John would be the first one.
Yeah, I had a feeling that I missed. Thank you.
Okay, great. Yeah, hello everyone. It's a real pleasure to be here and talk about this topic that we all have in common. I was told I should take about 12 minutes, and I'll try to summarize a fairly complicated study in that little bit of time. My name is John Pate. I'm a professor in our School of Public Health. I direct our Center for Managing Chronic Disease, and telehealth and digital health solutions is really the center of everything we do. We do a lot of work in the United States. We do a lot of work in Latin America in particular, among low and middle income countries. And in addition to my role at the University of Michigan, I, for a long time, have been an investigator in our National Veterans Affairs healthcare system. And I'm sure many of you are familiar with the VA. It serves about 8 or 9 million veterans of wars in the United States. These are mostly men. Their average age is about 63, 64. They're mostly low income. They have a high prevalence of chronic physical and mental illness and substance abuse. And really pertinent to our topic today is that they often travel, enormous distances to reach their usual source of care. So telehealth has been important to the VA for a long time and has been one of the main pillars of my own research agenda over the last 20 years. But today I'm going to be focusing on a comparative effectiveness study that we conducted in the VA. And we're just submitting the results now. And it's a study of patients that have chronic pain, chronic musculoskeletal pain. As I'm sure most of you know, pain is an incredibly important chronic illness. And in the United States, it's got kind of a double importance because not only is it a major cause of disability, but it's very closely linked to the epidemic of opioid overdose that we have in our country. And we just heard sadly that over 100,000 Americans lost their lives to opiate overdose in the last year. I happened to look at the Global Burden of Disease study. No big surprise. In terms of years living with disability in Israel, the top 3 are chronic pain conditions. This is very similar in the United States. It's very similar around the world. So back pain and pain management more generally are really an important priority for employers, for public health, et cetera, around the world. And it turns out that the main non-opioid or the non-procedure-based intervention for chronic pain works very well. It's called cognitive behavioral therapy. And in very brief, with CBT, patients are taught a series of skills to cope with their pain more effectively, to change some of their behaviors, to think about their pain in a better way, to practice relaxation exercises, et cetera. CBT is an evidence-based treatment. It's incredibly effective. It's the recommended treatment in our VA healthcare system and in many healthcare systems around the world. The bad news about CBT is that, as you can see, it typically requires a number of weekly sessions. And because of that, many patients don't get the services they need. I mean, patients with chronic pain, especially in the VA, but not only, have difficulty traveling to their sessions. They have back pain, so driving can be very difficult. Scheduling, stigma to going to something that they perceive as a psychotherapy. And there's actually a scarcity of CBT therapists for chronic pain. It's a specialized series of skills. It's often delivered by social workers or a psychologist that have a variety of other demands. So even though it's the recommended treatment in our VA healthcare system, only about half the patients receive the treatment that they need. So because of that, we conducted a comparative effectiveness trial that we published in 2017, in which we did a horse race. We compared standard in-person CBT for chronic pain in the VA to the same psychoeducational content that was delivered mostly by robocalls, mostly by IVR or interactive voice response calls. And I'm not gonna go into the details of that intervention, but it did allow for some personalization, but it was an automated system designed to be more accessible, the way telehealth is accessible, to reach patients in their home. The results of that comparative effectiveness trial were that the outcomes of this automated telehealth version of pain CBT were non-inferior, or less formally, we would say they were about the same. They were at least as good when patients were receiving this information via IVR calls, via telehealth, compared to when they received it by a trained therapist in the clinic. Their outcomes in terms of their functioning and their perceived pain intensity at 6 months were about the same. And the reasons for that are really important and have broader generalization for the field of telehealth more generally. What I say, I mean, I'm always very quick to point out that we are not saying that a robocall is quote unquote as good as a CBT therapist. That's not exactly what happened here. What you see here is a comparison across those two randomization groups of the number of visits that patients had out of their 10. I mean, they were supposed to have 10 total visits, but what we see is that in that lower line, when patients had to come to the clinic and sit with a CBT therapist for 45 minutes each session, many patients dropped out, or they stopped, or they missed sessions. So on average, they received about 6 sessions. In comparison, when they received a telehealth version with IVR calls, they received about 8 or 9. So even though each individual session might have been less potent, we can say, the overall dose of therapy was significantly greater in the telehealth IVR group. And that really explains the fact that the outcomes were roughly comparable. So even though that this was really an exciting finding, we still had this sneaking feeling that while the outcomes could be the same with an IVR telehealth delivered version of this particular therapy, we might be able to do a little better. There might still be patients in that IVR group that needed some personalization, that needed some more intensive personalized attention from a therapist. If we could just figure out who those people were and deliver the therapy to make sure that everyone got all the treatment that they needed, but not one bit more, we might actually be able to beat standard care. So that was the logic of the follow-up trial that, as I mentioned, we are just now submitting for publication. It was called the REACT trial. And the REACT trial was another comparative effectiveness trial. In this particular instance, the control group was, again, therapist-delivered CBT for chronic pain, 45-minute sessions over a period of 10 weeks, but it was telehealth. I mean, it was therapist live CBT delivered by telephone, but the intervention group used a specific type of artificial intelligence called reinforcement learning to decide exactly how much live therapy patients need. So I kind of honestly think that Israel is often one of the leaders internationally in artificial intelligence. There may be people with us today that know much more about AI than I do, but in very brief, reinforcement learning as a subtype of AI is very much a process that's meant to mimic how we learn in the real world through a process of trial and error and feedback. So it's like how we learn how to ride a bike, how we learn how to play chess. We try certain things, we get the outcomes, good or bad. We slowly kind of, adjust our behavior to fit that learning cycle so that we can optimize outcomes over the long term. So more specifically in reinforcement learning, what one does is one identifies an outcome that you seek to optimize, and that's called in our L terms the reward or the reward function. And the system collects those data on those outcomes frequently. In the case of this particular trial, or over the course of a week, and evaluates its decisions or action choices based on what's happening to that outcome over time for that individual patient, for other patients. So I hope that makes a little bit of sense. In this particular study, the outcome that the RL algorithm was trying to optimize was a combination of patients' step count, so an objective measure of their physical activity, and their IVR reported pain interference scores. So that's something that they reported each day during the intervention, during an automated IVR call. You can see this little man here in the middle, he represents the RL agent. And based on trying to optimize that outcome, the RL system each week for each patient made a decision about whether they needed an hour-long conversation with an CBT therapist, or maybe just a 15-minute brief conversation with that therapist, or they could have an IVR delivered session like we did in the prior trial, in the COPES trial. So that's basically the RL system that was running over the course of 6 months. I won't go into all the outcomes. The primary outcome was a common measure of pain-related interference called the Rowland-Morland Disability Questionnaire. And at 3 months, there was a statistically significant better average RMDQ score in the AI group than the control group. So again, compared to patients getting 45-minute sessions with a therapist, they actually did better, slightly better, statistically significantly better at 3 months at the primary outcome in the AI group. At 6 months, they did substantially better, actually, in the AI group. They had the number of patients in the AI group that had clinically significant changes in this common pain measure was twice as great. Twice as many patients at 6 months had clinically significant improvements. And we saw something similar at 6 months in terms of patients' reports of their pain, basically their pain intensity. Substantially more patients were reporting that their pain was better when they were receiving this AI-driven combination of live and IVR delivered therapy than when they had the standard therapy. And this is another really interesting and important point, generalizable point for the field of telehealth. Remember, I said that in the comparison group, patients were assigned 10 45-minute live conversations with a CBT therapist. And even though that they were getting some of that therapeutic content via IVR and via shorter sessions in the intervention group, they still attended more of those sessions than the live therapy. And anecdotally, that's what we hear from patients, that they frankly don't really want to necessarily talk to a therapist for 45 minutes over 10 weeks. They'd really thank you if they're doing fine, they prefer to get that content in another way, in a more efficient way, and even in an asynchronous or automated delivered way. So they got more sessions of treatment like they did in the prior trial, but on average only used about 30% as much clinical time. So as we're thinking of really disseminating these evidence-based therapies using CBT or other similar interventions for depression, anxiety disorders, chronic pain, et cetera. These sorts of AI-driven models, I think, are a very promising way to make sure, as I said before, that patients get as much attention as they need, but not one bit more. Finally, I'll just say very briefly, we did some simulations that showed that the AI algorithm could improve outcomes not only during the course of this trial, but as it's learning from experience, that it would continue to learn, it would continue to get better. So these are the types of interventions that are really ideally implemented on a large scale, which is a little countercultural, frankly, for our research model, where we begin with small pilots and single site studies. But these sorts of things that learn from experience, that learn from evidence, can get better over time. So large collaborative studies are really ideal. And I will stop there. Thank you for your attention.
Thank you very much, John. That was very, very interesting. Maybe I'll kick it off with one question that occurred to me. You mentioned that the patients that were in the studies were VA veterans. I assume they were a bit older age-wise. Did you find that these patients were more hesitant or had more difficulties adopting your newer technologies, or did you maybe some needed like focused training or explanations, or was the implementation pretty smooth?
Yeah, Ron, that's a great question. There's two things going on simultaneously that I think have kind of countervailing effects. One, as you mentioned, they are older, and older patients have a little more difficulty using technologies. On the other hand, these are VA patients, and VA patients, military people, they're quite compliant. They like the VA healthcare system, and just kind of by the culture, they're very compliant. So patients were asked to report on their pain every day. And on average, I mean, overall, they report like 88 to 90% of the time every day. So I think that's a unique thing to the VA. Doing this sort of intervention outside the VA would benefit from maybe more passive ways of getting that feedback, of how patients are doing.
Great, thank you. Another question that we're getting from Michelle, she's asking which parameters were used for AI screening?
I'm not sure what that means, AI screening. You mean the outcome? I mean, I'll answer. I'll do my best. The reward.
Can I? I'm sorry.
Sure.
Can I?
Yeah, please.
Yeah.
Okay. I just wanted to make sure when you did the separation between the groups, and you used what you said it was the reinforcement learning, right?
Right.
How are the criteria for the computer or the machine to assign patients to each group?
To each of the session types. So those
Yeah,
are
the session types. Yeah.
Great. Yeah, great question. So the primary outcome, the reward, was this combo of patient-reported step counts, their physical activity, and their reports of their pain-related, their functioning during the week. You may know that these systems take into account contextual data about the patient each week. So it did take into account what's called state-space data. So that's other things that the patient reported each day in terms, which were things like their sleep quality, and their practice of the CBT skills. So you can imagine if someone said like, yeah, I'm doing pretty good, but I'm definitely not practicing these CBT skills, the system could then learn that they might need some more personalized attention to stay on the right path.
I understand. And for how many weeks the step counting and the pain scores were evaluated?
10 weeks. That the primary outcomes was really at 3 months, and the intervention was for 10 weeks.
10 weeks. Okay, thank you.
You're welcome.
Okay.
Great.
Thank you very much, John. That, these are really very interesting studies, and congratulations on that. We'll be moving on to our next speaker, Naomi. And Naomi, please feel free to introduce yourself to the crowd.
Share my screen. Can you all see?
Yep.
Yeah. Okay, great. Thank you. So my name is Naomi Geffen. I'm an occupational therapist. I'm the Deputy Director General of Aline Hospital, a pediatric rehabilitation hospital in Israel. I'm also a principal investigator in the Helmsley Park Research Center in Aline. And also I had the allied health work group in the telerehab, in the telehealth consortium here today. So we're going to talk about pediatric telerehabilitation, and we're going to talk from challenges to potential solutions. Sorry, my computer is not working. Okay, so when we talk about telerehab, I just want to make sure that we're all on the same page. We are talking about, it refers to the use of information and communication technologies to provide rehabilitation services to people remotely in their homes or other environments. And when we talk about pediatric telerehabilitation, of course, we're talking about the same things. And you would think that the kids would love it, right? It involves screens and it has lots of screen time to be able to do the different therapy sessions, and that parents would hate it because it involves a lot of screen time when doing the therapy, and it involves many of their apprehensions, but it's not so clear cut as we saw. Just like Chad was talking about the statistics, we too in Israel immediately transitioned to telerehabilitation without any thorough planning beforehand. We had done some minor studies in Aline doing telerehab, but nothing major. Overnight, we had to start doing individual group sessions, multidisciplinary clinics, because children were not able to come to the hospital. And we also had to release kids that were in the hospital home to make sure that we could have social distancing in the rooms themselves. So the PTs, OTs, speech psychologists, and even the physicians themselves were doing telerehab. And we were using the basic platforms. We were using the phone, the WhatsApp, Zoom. We were trying to get more sophisticated in the way that we use these basic platforms. But basically, these are the platforms that we had to use in the 5 months that we were doing telerehab more intensely. So we decided to follow what we were doing in a naturalistic study, and we looked at the data retrospectively. So 144 children participated in telerehab. We had 61 therapists over the 4 different sectors that I talked about before. Around 2,500 therapy sessions. Therapy sessions were given between March and July of 2020. And we had 2 focus groups to try and understand what the challenges were through the perspective of the therapist and the families and the children themselves. So the 2 groups themselves, 2 different groups, one with the professionals about 8 weeks into doing telerehab, and the family and children focus group we did at the end of after July. We looked at the information that we received in the focus group via a SWOT analysis, and we did a thematic analysis according to the strengths, opportunities, weaknesses, and threats, looking through SWOT. There were many themes that came up. There were a lot of issues about technical problems, the setting that the telerehab was given in, the connection between the therapist and the patients themselves. And for example, I want to take one example here because it'll relate to the rest of my presentation a little bit later. So when we look at the home setting, black is therapists, red are the families. So when we look at the weaknesses, everyone could identify weaknesses. The therapists themselves, there wasn't appropriate equipment at home. They wanted to work on range of motion or wanted to work on strength. They had to identify different equipment that was there. The families felt that there were a lot of distractions because it was a lockdown and the siblings were home, and they had to find a specific place for the parents, for the children to be able to get therapy. If we look at the strengths, the therapists felt that it was very good because they were able to identify environments and equipment that they could use at home. When we treat the children at the hospital, we're seeing them in the clinic, and we want to make sure that the goals that we work on relate to what they're enduring at home. So at the beginning of our telerehab, we took a video and the parents themselves walked around the house, and we were able to identify better environments for them to do the telerehab and what we could use using home equipment to be able to do telerehab. The threats, the therapists were very concerned that they lacked hands-on. Allied health professionals, OTs, PTs, speech, we do a lot of hands-on therapy, and that was something that we were lacking. As another threat, the families themselves talked about the fact that they felt exposed. Some of them did not want to turn on the video. They didn't want to show their home. They would show only part of it, or cultural issues became apparent when a mother did not want to be videoed or be shown in the video. But we also had to look at the opportunities. It enabled us to look at the family dynamics, and it enabled families to participate in therapy. We saw a lot in the psychology sessions where sessions could now be done with both parents and at different times of the day. So what we decided to do is to look at all these challenges and to try and see how we could utilize different technologies to be able to bridge some of those gaps. So how are we going to be able to maintain the high touch in the era of high tech? Well, so we have the telerehab on the one side, and we have in-person rehab, just like what you showed, Chad. Also in Israel, as soon as possible, the therapists and the children wanted to go back to in-person rehab. And that's what happened. In-person rehab, you can show empathy, there's handling, we have access to equipment. But on the other side, when looking at the tele-rehab, parents did talk about the fact that it was convenient in a lot of times. It enabled us as therapists to work with the parents and children to develop good habits for homework in between the therapy sessions. So if we look at both in-person and tele-rehab, what we want to try and find is a hybrid approach to try and benefit from both of these worlds. So in Alin Hospital, we have the Innovation, which is our innovation space. And we work with a group, about 12 different startups, developing different programs for children in the area of technology. Not all of them at all are in the area of tele-rehab. And I want to focus on some of the companies that we worked with starting after COVID to try and use their technology to be able to bridge some of the gaps and challenges that we're talking about. So the first company that I want to talk about is Augment Therapy. Augment Therapy is a US-based company that we came across in KidX, which is a forum of US-based hospitals, children hospitals, that enable us to work on different challenges to try and see how we could bridge the gap of different challenges, not necessarily in telerehabilitation. So we came across Augment Therapy. I'd like to show and tell me that you can see, please. This is Augment Therapy, and now the challenges that it's trying to bridge here is this. OTs and PTs said that they had a lot of problem with the fact that they didn't have appropriate equipment at home. They didn't have appropriate programs that they could use online to be able to work with the children. You can see here, this child here, the little frog on the side is showing the child what she needs to do. The woman on the top right is a therapist that is working with the child at home doing tele-rehab. I just want to pause that 1 second and just show you one more thing. On the top corner, you can see that it's counting the number of steps that the child has done, the arm movements, and the stars that are written there are the motivation that the kid gets by doing it correctly. This program has different programs for upper extremity, lower extremity, and it really helped the therapist, helping the therapist work on the gross motor activities that they were lacking to have the proper programs. Another thing that you can see here on Augment Therapy is you can see here that another game that the child sees a string avatar. It's a game that that's a goalie. The therapist can set up what extremity should be used to be able to be the goalie here. It could be, you can see at the moment that there's 5 dots at the moment, head, 2 arms, and 2 legs. But you can set it up that, for example, to use only the left leg or only the right arm. And the child sees himself, herself, and the therapist herself as well. So that's one company that we've been working with to try and see how we can use it in tele-rehab. And we're working with them in a design participatory a way of research to be able to change this, to use this system in tele-rehab. They're even translating it to Hebrew for us as well. Another company is an Israeli company called Sorah. They have developed an APT, an active passive trainer. It's something that's very, very common in rehab. It can be placed on the floor to be used with legs or arms, or on the table to be used with arms. And it's used a lot for adults when you want to work on endurance and on range of motion. But when trying to work with it with children, it's very boring. I mean, it's like a cycle. It's a cycle, and children aren't necessarily did not want to necessarily participate or collaborate or participate. So what they're doing now is they're developing motivational games that interact with the APT, and we're working with them to see how that we can use that in tele-rehab, because it's, on the one hand, will enable us to monitor what the children are doing, but on the other hand, we can use that in tele-rehab so the therapist and the child can share the same program. Another company that we're working with also Israeli called Cuniverse. What it is, it's tiles that, like you can see on the bottom right, tiles that are 50 by 50 centimeters that can be connected either in a square or in a line. It can be based on the floor, table, or wall. And here too, you can work on gross motor activities, but you can also integrate into that cognitive and do multitasking type of activities. You can see on the left, remote assistant, it's a therapist on the other side, and also it enables telerehab. And we can work on balance, range of motion, cognitive sequencing. We're in the midst of developing that, and we're working with that as well. The last company that I want to talk about is also an Israeli company. It's called Cognishine. Cognishine is a computer program that works on 4 different domains: cognition, communication, speech, and social emotional, as they call it. They actually started in the United States, so what you're seeing here is English. They've also translated it to Hebrew, and it is culturally appropriate for people in America and also in Israel, meaning that that the content, they would talk about Valentine's Day, for example, and in Israel, they would talk about Israeli holidays for children. What it's doing is it's basically taking over the game cupboard where a therapist would go and to take a game to play, for example, memory. The content here is appropriate for adults and for children, and it enables children and OTs and speech therapists to work remotely with the children. I'd like to show you a short video. Can you see this? 1 second.
No, we can't see.
No.
We still
Okay.
still see the presentation.
Yeah. I will do that. Here we go. Okay, so this is a speech therapist who is working on the letter L. I'm sure can you hear it? No, you can't hear. That's okay. So she's working on the letter L, and what she is going to be doing is she is able to decide what letter she wants to work on, where the position of that letter is, how many times it should repeat itself. You can see here she's choosing the letter, what the position will be in the word, and so it gives speech therapists an option to work doing telerehab with the children wherever they are. I want to stop sharing that and go back just a second. Okay. Almost done. Just a second. Okay, here we go. Okay. So in summary, telerehab we feel is here to stay. We need to make sure that we have the appropriate equipment and programs to enable it to be as utilized as best as possible. We want to make sure that it's engaging for children, that you can monitor what the children are doing. It enables gross motor activities, and we need to evaluate the effectiveness of the different systems. Thank you very much.
Great, Naomi. That was a awesome presentation. I was when I saw that augmented tele-rehab, I was just thinking of how crazy my daughter would go if she saw some kangaroos and frogs on the screen by doing rehab. So that's really interesting and very innovative work. I do have a couple questions for you. One is just kind of the general status of tele-rehab now that a lot of in-person care has resumed. Do you know, in terms of just at the population level, has this gone down to a small percentage of rehab care being delivered? Is it still, a big percentage?
Okay, so in the area of allied health professions, it's gone down tremendously. I mean, yeah. Everyone wants to go back to in-person, even though as therapists, we do feel that it has benefits. In the area of physician consultation, it is still at a high level. I can't give you numbers. Maybe Esty knows more than I do, and we can talk about that at the end, but I don't know the numbers. But physicians are doing much more. Psychologists are, the numbers are still high, but OTs, PT, speech, teachers, it's gone down. But we are doing many studies now to show the effectiveness of it, to be able to try and promote it with the Ministry of Health and also with the therapists themselves.
Great. And we have a question from the audience too, just regarding, and this is an issue that we have with a lot of telehealth, is just reaching those populations that could certainly benefit from it, but may not have the means to do it because of socioeconomic barriers. So like what kind of solutions do you think would be necessary to reach those particular populations?
In Israel, a lot of even the low socioeconomical levels of family households do have smartphones, and a lot of the telehealth is provided through smartphones. So that's an opportunity. The Ministry of Health provide children when needed with computers, and the Ministry of Education provide children with iPads and computers if when needed, so that they do have access. It could be asynchronized telerehab, so we could access it and then work with it offline. But because we have universal health coverage, a lot of the equipment is provided through either the Ministry of Health or the Ministry of Education for the children I'm talking about.
Great. I think so. That question came from Shemuel. Do you have any further clarification that you wanted on that particular question? You can unmute to ask if you want. Okay. So I think we're at time now, so we'll move on to the next presentation. This is going to be from the U.S. Factors influencing patients' initial decisions regarding telepsychiatry participation during the COVID-19 pandemic. Jennifer, we're going to put you on the screen here if you want to take over.
Thank you. Hi, everyone. I'm Jennifer Sevier. I'm a clinical assistant professor at University of Michigan. I was one of the champion psychiatrists pre-pandemic trying to establish telehealth in our clinic, and I tried a few video visits. My project was mainly to see how we can help patients who are missing their appointments to eventually convert last minute their appointment to a video visit and see if that could help. And as you will see, eventually the pandemic hit, so things took a different turn. Let's see here. Sorry about that. So I have no conflict of interest. This is a long study, but I will try to summarize it and also talk a little bit about the lesson learned. So this is our outpatient clinic where we see about 60,000 psychiatric patients every year. And in this clinic, we used to have a high rate of no-shows. We are a small team of psychiatrists, mental health providers, not only psychiatrists, but also psychologists, social workers. And we are the referral clinic for many clinics around Michigan. And pre-pandemic, the hope was to start converting some no-shows or start seeing who might be interested in video visit. Unfortunately, we launched in 2019. By February 2020, we only had 26 visits, and it was very difficult to get patients to engage in video visit for several reasons. Some people just felt that it was something very new, they were not comfortable with, and also based on the nature of our work as mental health providers, as you know, therapeutic relationship matters a lot. So some people felt that technology will immediately remove that. And we continue to put the effort until February 2020, as I said, when prior to the pandemic arriving in Michigan. But by March 23rd, 2020, our governor declared that people should need to stay home. And there was the Michigan executive order where the people have to stay home, stay safe, and that could save lives. And that's when we turned to video visit. And if you can see from 26 visits, pre-pandemic, during the pandemic, we end up having 100% of our outpatient clinic to convert to virtual visit. And again, it's interesting because when you look at other specialty, neurology was a second, and family medicine was the third to follow with a virtual visit to be able to adapt and have patients to video visit. What happened is the nature of the work we do, it's not for every patient we'll do a physical exam. For every patient, we don't have to have labs to start treatment. So it makes sense that converting to 100% virtual visit was possible in psychiatry by June 2020 compared to other services. However, it's kind of also interesting to see prior to this how difficult it was. So when we saw this happen, that's when we started wondering then what's happening, because we know we've been trying. I know personally how much effort I put into promoting telehealth with my team, and nothing was happening. Really, we're not getting enough traction. So now we are 100%. We need to know if we're doing a good job and what's happening. Especially also, we were offering both video visit and phone visit. So we wanted to know who was picking up phone visit, virtual visit, and why. So what we did, we put a team together of people from my department and also from the Office of Patient Experience, where patients can call and report their experience with care, but also with virtual care. And also we had a few volunteers from the medical school and undergrads. We decided to do phone calls to reach patients, and this survey was conducted only by phone, and that was done during the first 3 weeks of the stay-at-home order. So when the Michigan executive order was released on March 23rd, we count from that day, we immediately, within a couple of days, converted every face-to-face visit to virtual care. So new patients and old patients. So we started counting from that week and 2 weeks after. So for the first 3 weeks, all those visits that were converted, patients were given the option to either pick video visit or phone visit, but what really make them pick one over the other? So what we did, by June, we decided we will be calling those patients who had to change their visit during the first 3 weeks. And we call a total of 1,030 patients. And 433 patients answered our calls. And we were able to enroll 244 patients in that survey. So they completed the survey, they answered all the questions we had. And those were the Office of Patient Experience, mostly the undergrads and the medical students who were doing those surveys by June, since the medical school had changed the curriculum and the way they were providing training. So the medical student had some time to help us with this. And we realized that among the people who were able to reach the 431, as you can see, maybe half only responded. And when we look at across Michigan, it's actually the way it is. Phone surveys are usually about 48, 55% patients you will be able to reach through a phone survey. So we felt that showed exactly how many people we could reach. We hope we had reached more people. And we also had 187 people who did not complete the survey. None of them were wrong numbers. Some people asked to be contacted later on, and some other people just didn't feel that they wanted to continue with their survey, what was appropriate to them. So total, we had 244 participants. And among those participants who answered the survey, we had 87% patients. So keep in mind, we were calling from the adult outpatient clinic, the children and adolescent outpatient clinic, meaning kids, parents will pick up the phone for them, or you may call, and if it's an elderly patient, a family member or someone else may call may pick up the phone and do the survey for that patient. So participants who answered were 80% patients themselves, and 17% were parents of those children or proxies or the people who asked someone else to answer the survey questions for them. We had 68% were female of the participants. And in terms of age, we had 61% adults between age 18 and 64, and we have 20% minors younger than 18 years old, and 18% were seniors, 65 years old and older. And we had patients as old as 80 years old in answering the survey. We had 77% of our population were white, and we had Black, we had Asian. So when we were gathering those characteristics, we were trying to keep in mind, okay, we want to see if a choice between a phone visit and a video visit will be driven by sex, whether it will be driven by age, whether it will be driven by racial ethnic groups, and whether also it will be driven by how established someone was already with us before the pandemic hit. Meaning, where you are established patients who are already coming to the clinic, who had multiple previous appointments with us, who maybe feel already comfortable with your clinicians and who would prefer to do, maybe phone visit will be enough for you. Or where you're like a new patient coming to see us, and perhaps you want to have a video visit instead of a phone visit so that you can see your provider face-to-face and have and develop this therapeutic alliance, this relationship that we know is very key in mental health care. So that's why also we're counting how many clinic visits patients had. And also we did look at insurance, and we found that some patients, like the local insurance here in Michigan, BCBS, Blue Cross Blue Shield, 27% had that. We also had some Medicare patients, 60%. We had managed Medicaid patients, 60%. But we didn't have straight Medicaid patients because in our state, which is mainly patients who have chronic severe mental illnesses managed and by the state of Michigan, they have a different clinic, which is community health clinic. So we didn't have this type of health insurance included. And again, we're just trying to see if the type of insurance will make patients favor video visit over phone visit. So those were the initial results. So what we see is 88%, on the side, 82.8% of patients chose video visit. And as you can see here, a video visit sounded more convenient. The first reason why people pick video visit is because it sounded more convenient to them. And some said second reason, they felt more comfortable using the technology. So I will not have time to go through all the answers. This data was published, and I'm happy also to share my slides with you. But it was interesting to see that the top two reasons where video visit sounded more convenient, and that people were already comfortable with using video visit. Something else that we noted was when it comes to phone visit, it actually was a little different. The first reason was, again, people felt more comfortable with phone. And so they picked to have a phone visit. But also the second reason for picking a phone visit was, I tried a video visit in the past and it didn't work. So it's again, keep in mind, those were people who make the first, during the first 3 weeks, meaning months after, maybe some people switch from video to phone, from phone to video, we don't know, but that was the initial reasons why people pick one over the other. And when we were looking at some of the patient characteristics, we realized that actually only age made a difference between choices between video visit and phone visit. And patients who were 44 years old and older, they were more likely to choose phone visit compared to patients who were younger than 44 years old. So it's kind of like this trend that we were already, we kind of foresee that patients who are older will be most likely, maybe elderly patients may not have the willingness or maybe the readiness to use the technology. So we kind of like started seeing that in the first week, and we started working on this project, which was parallel to this, some of the authors who were working on this with me studied this project called the Get Access, which is the Geriatric Education for Telehealth Access program. So what we did, this program was tailored to provide education to elderly patients to increase the comfort, increase access, comfort, and participation in video visit. So it was kind of interesting when we found that age was a key factor, and we know we were also working on developing the Get Access. Actually, I was not part of this project, but Dr. Blasek, who is a geriatric psychiatrist, she was the mastermind behind this for our clinic. So it was kind of interesting to see this happening at the same time, and quite also exciting to see ways we could support our patients. And again, there were medical students involved in this who were quite helpful with this project in educating patients on how to utilize video visit telehealth care. And we started also wondering, okay, since prior to the pandemic, it was so difficult to establish video visit, is there any way that people may want now to continue with it? Now they're getting more comfortable. So I know this was an early question, maybe too early in the pandemic to ask, but since we didn't know where things were heading, so my thought was, let me just ask and see how likely people are to continue with video visit after the pandemic, and because we need to get ready for this. And we realized that actually people felt that virtual visits were more convenient. It reduces the risk of contracting COVID-19. And again, there was this uncertainty as to how long the pandemic will continue. But if we were able to actually make the space safe, where will people be able to come back during the pandemic? And that's where we realized that some people were ready to come back during the pandemic, actually 47% of them. And the reason they listed were, if we were able to take precaution to protect patients against the virus, or based on their provider recommendations, they were willing to do it. Based on state government directions or orders, they were willing to do it. And again, I think at that point, as you may imagine, there was no vaccine. So that's why we didn't also check whether if they were vaccinated, if that will change their comfort to come back in person compared to virtual visit. But those two questions at the end of the day meant two things for us. First, are we seeing here a new trend where virtual visit will be widely adopted? And we know in our field of work in psychiatry, it can be easily, we can provide care easily to patients compared to other specialties. So are we seeing a new trend here? But let's gauge people's interest in continuing with this. And second, since we don't know how long the pandemic will continue, how can we start foreseeing for some patients who may need to come back in person, what they may need to happen? And at the end, one of the questions across the board was, were you satisfied with your virtual visit? Was it met, or did it exceeded expectations? And 94% of the participants responded positively, and they really liked their video visit. Thank you. And this is really one of my favorite pictures, since it really highlights our waiting room in the depression center, where our outpatient clinic is located. And currently it's empty, and it's really emotional when I used to remember how full it used to be, but now being mainly virtual, although we still offer some in-person visit, it's kind of almost surreal to see this room empty. Thank you.
Jennifer, thank you very much. That was really interesting. A question that came to mind to me was, did you also look into the resources that the patients had and to try to understand maybe that influenced their preference of video versus telephone call? Maybe somebody with a higher socioeconomical status would prefer video versus a lower would prefer telephone. Did you look into that as well?
We did not, and that was one of the main weakness of our study, is the social economic aspect of it. So what we were thinking initially was, let's look at zip codes and see if we could, per zip codes, start thinking If someone is remotely located, maybe they have lower access to certain technology, lower bandwidth, but our sample size was not enough based on all the zip codes we had to really come up with data that could help us determine that. And again, but the socioeconomic aspect was another aspect that I wish we had focused on more, and I hope other studies will.
Okay, and maybe just one more question coming from the audience from Shmuel Yerushalmi. He's asking, according to your experience, would you anticipate that the rise and growth of telepsychiatry will continue in the post-COVID era as well?
Yes, I do feel confident that it will continue to rise. And sorry, I just published another study that we did in remote area with patients with chronic and complex severe psychiatric illnesses. And we were surprised to see how engagement in both medication management and psychotherapy was actually quite high. So it means two things to us. First, and that study was done in Arkansas, Washington State, and Michigan State, and more than 1,000 patients. So we're talking about it's not only depression, anxiety, certain psychiatric illness that can be treated through video visit. Even chronic severe mental illness can be managed for both medications and psychotherapy, substance use. So I think that was quite refreshing to see too.
Okay, again, Jennifer, thank you very much. And I'm sure that we have a lot to look forward to in the field of psychiatry and telecommunication, telehealth. Thank you so much for your talk. We're now going to hand over to Shoshana Yeshayahu, and we're going to hear your experience about cardiac rehabilitation.
Where am I? Maybe it's this one second. Trying to open it. I'll share. Sorry. Okay. Sorry. Hi. Do you hear me? We're good? Okay.
We hear you perfect.
Okay. Hi, my name is Shoshi Yeshayahu. I'm an exercise physiologist in the cardiac rehabilitation program at Tel Shomer or Sheba Medical Center in Israel. We had the first national program of remote cardiac rehabilitation. We started it back in 2019, where we did a pilot. We wanted to see how remote cardiac rehab would work, because the big problem is that most people after a cardiac event don't end up getting the help that they need, meaning they don't go into a cardiac program. About 70% of the patients do not go into a cardiac program for many different reasons. It could be that it's not convenient. They live in the periphery, and most of the cardiac programs here in Israel are in the center of the country. Their transportation-wise, they couldn't get there. It wasn't convenient. They had work. If it was younger patients and older patients, sometimes just didn't have a way to get there, or they couldn't. Part of it was they would come and there's a problem with parking in the hospital, or or some of the patients didn't want to come because coming to the hospital would give them it'd start anxiety, and it would take them back to the event, and they just didn't want to be in the hospital, and it would raise their blood pressure. They just didn't want to be in the hospital. So about 70% of the patients don't get the help that they really need. So we did this remote. We started a remote cardiac program. We did in the first pilot that we did. We had we had about 60 patients, and after the events with what we had gotten from the program, we then the Ministry of Health gave us the okay to go ahead and continue this program. Most hospitals in Israel now use this model on their programs, and it's like I said, and it's now really working. So what our program is based on, the patients get a smartwatch, sport watch. They get an application on their telephone, and then they have access to a whole team of experts, cardiologists, nurses, exercise physiologists, exercise trainers, dietitians, psychologists, and we all work together to give the care to these patients. They see the application, they can track their progress and their exercises that they do on the screen. We as the care team, we can talk between us, we can send notes to each other, we can send information about the patient so that they get really an overall health benefits from the program. Once a week, they get a phone call from the exercise trainer who then talks to them about the exercise and how to continue and how to challenge them in order to get better results. So basically, also what we wanted to do is, what we really wanted to do in this particular study that we did, we wanted to see people, we're talking about telemedicine, we're talking technology. So we wanted to see if it was only good for younger patients, or can older patients also benefit from this technology? Because people are like, oh, older people, they don't know the technology, the smartphone, they don't know how to use it. Is it convenient for them? Maybe they don't want to use it. So we did a retrospective study where we took we took 306 patients that we had of all different cardiovascular backgrounds, and we wanted to see we wanted to see two things. The objective of the study was, one was to see the patterns of physical activity, goal achievement, and improvement of functional level among participants in the program, comparing under 65 and over 65. And the second study was the second objective was to study the variables that can predict a patient's adherence and compliance to the program. So we wanted to see if we can predict a patient who starts in the program, if he will continue in the program after the 3 months of exercise. And so first of all, what we found, the goals that we give to the subjects, the patients, not subjects, to the patients in our program are a minimum of 150 minutes of aerobic exercise per week. Within that parameter, 120 of the minutes should be within a target heart rate that the patient gets after they've done a stress test, and 8,000 steps per day. So those are that's the basic goals that we wanted to see, and we want to see if they adhere and they comply to these goals. So what the patients do before they come into the program, they are given a stress test before the program, and 3 months down the line, they're giving another stress test in order to see how we can to track their improvement. So first of all, we have seen that all the patients, okay, whether of all the ages, do comply with the average minutes. Okay, they're even above average they were, and most of them within the target heart rate. However, we do see that people over the age of 65 have actually they actually do more walking or do more exercise per minute minutes than younger patients do. Okay, so we have this chart, and this is just things that we tracked. Sorry, you can see and we've seen that all the patients do comply. They've all been above average for all their exercise and goals. We have seen that the improvement in functional capacity, like I said, we give the patients a stress test before the exercise. We give them a stress test 3 months after into the program. And we checked, we looked to see the outcomes. What we have seen is that at the beginning, the pre-exercise, as you can see, patients who are under 65 are obviously at the beginning they were a little bit more, they had more of a functional capacity. They did better on their stress test than patients over 65. However, post-tele cardiac rehab, that means after 3 months, when we gave them the retest, there was no significant difference. And the big change was that older patients have a much bigger change in their functional capacity, much bigger improvement, in their functional capacity to do exercise than patients under 65. Sorry, no, where am I? Oh, okay. Sorry, okay. And so we had, and then the second objective, like I said, that we wanted to see, does it change in compliance, or can we not change in compliance, can we predict who will comply and who will adhere to the program? So we took three parameters of according to their age. We looked at the people who didn't stay in the program for 3 months. We looked at the characteristics of the people who stayed in the program for 3 months and had achieved a target heart rate of over 400 minutes per month, which is at 120 minutes per week. And we looked at the characteristics of people who achieved over 600 minutes of aerobic exercise in the 3rd month, and that they complied with the 150 minutes per week. Okay, so the average age, as you see here, was 60. Like I said, oh, I didn't say, but what I wanted, we had of the 306 patients that we checked, 80 of them were over the age of 65 with an average age of 70. And what we see here is that the outcome by age group, that we have the first 3 months of who reached the target heart rate and the first 3 months of the total aerobic minutes. And as you can see, the patients who are over 65 significantly had more aerobic minutes within the first 3 months, as well as in the first 2 months they reached their heart rate more. The 3rd month was slightly less. They still had more. They still reached it, but it wasn't a significant change. Okay, so like we see, there was definitely a significant change in the total amount of aerobic workout minutes that they do. So we looked at the predictive models for the last month. Like, can we see who will adhere and who can continue in the program? So in the first thing, we see the 400 minutes of exercise in the 3rd month. And what we see is that the age, okay, so the older you are, above 65, the older you are above 65, every year gives you even more an advantage that actually to continue in a cardiac rehab program with the mean workout intensity in the 1st month will show us if will predict how you do in the 3rd month, I'm sorry, and the total aerobic minutes as well. If you are above the 150 minutes within the 1st month and you adhere to it, you will then continue and adhere to it and even improve it in the 3rd month. We then looked, and another predictor was that the steps. So if you kept to the 8,000 steps or more, then you would get to the 600 minutes of exercise after the 3rd month. And what we have seen actually is that not only is age not a limitation, it's actually a good predictor of if somebody can continue in cardiac rehabilitation, telecardiac rehabilitation. The older you are, the more you were able, they actually thrived in the program, and we were actually quite surprised when we saw we had some models, we had some exercise programs that we did during the pandemic, at the 1st month of the pandemic, when we were all in lockdown. So our in-house cardiac rehabilitation in the hospital was stopped and people did not come. We continued the telerehabilitation, obviously, and not only do we see an improvement in the way they exercise and the continuity of exercise, they continued it, they didn't stop it, and it was quite interesting that when they weren't even allowed to go out, they still continued to exercise in their house. We gave them exercises to do, and they were able to do it. I'm going to give it also slight, a little bit of a video. If you can hear it, 1 minute. No, that's not it. Wait. Sorry, 1 second.
I think you need to go out of share screen.
Can you hear it?
You may need
Can
to
you hear it?
you may need to come off of share screen and share the screen where the video is
Oh,
playing.
the share. I have to share the screen. So,
Yeah, we are still seeing the
wait a second.
presentation.
I'm sorry. I'm sorry.
No problem.
Wait. Sorry. Let me see. I'm sorry. And what do I have to do? I have to share the screen.
Share the browser.
You
You
have
need
to
to-
stop sharing this one first.
Oh, I have to get out of. Okay. 1 second. I'm sorry. Oh, so what do I?
You stop
Um,
sharing your screen and you reshare the screen you want.
Okay, I'm sorry. I got it. Okay, so wait, why can't I see the share screen? 1 second.
The green button in the middle.
The button in the middle. Yeah, no, I know, but I can't. I had it before. Now I don't. Hold on. I'm sorry. Wait, no.
Now you feel like a patient.
I do. Now I do. Now I feel like I don't know what I'm doing. 1 second. I'm sorry. Why can't I see it? I lost it. Wait, hold on 1 second. I'm sorry. Wait. Okay, wait. No, I have to stop. 1 second. Oh, this I have to stop. Hold on. Sorry. I feel like. Wait a minute. All right, I'm not going. Wait. I have to stop this. Wait, okay. I'm now in now.
Shoshana?
Guys, I'm sorry.
No
Sorry,
worries.
Shoshana.
Oh, okay, now I have it. Now I'm there.
Okay.
Okay, I got it. So now I have to go into. I stopped sharing the screen.
Hey,
And now
just-
Yes, you're not sharing screen.
okay, now I'm not sharing the screen.
No.
Okay, and now I go into the. Okay, 1 minute. Okay, so okay.
Shoshana, we have some
Shoshana?
we have some questions, so maybe we can talk about your study and
I'm sorry. Yeah, sure.
hold off on the
I'm
video.
sorry. I can't.
It's okay. I know it happens all the time. It's ironic when we're talking about telehealth that there's always technological issues. Yeah, but thank you. That was a great presentation. It was really interesting. I don't know much about cardiac rehab, but I could see the important implications of that. And also there seems to be a lot of themes between the multiple presentations that occurred, regarding rehab. And in particular, I'm interested really in compliance. It almost seems like, if there's a pathway to improvement in quality or non-inferiority between in-person, that pathway may be through compliance. And I just wanted to see, I don't know if you have it from your study or if you just have a general idea of how compliance compared with telecardiac rehab versus in-person.
Right. So we did a study. In our studies, we found that there is no difference. They've complied in both things, but in both remote cardiac rehabilitation and in patient cardiac rehabilitation. I found that with the remote cardiac rehabilitation, there's a lot. There's certain thing. I think it's not for everybody because there is a certain self-discipline that you need in remote cardiac rehabilitation. So, but for the most part, people are very compliant. I think more compliant actually in the remote cardiac rehabilitation because they tend to do, or we can see it, we can track it. For example, if somebody comes into the cardiac in the inpatient, we only see them the twice a week that they come, the 2 sessions a week that they come. We tell them to continue exercising. Do they do it? Do they not do it? We don't really have a way to track it. Whereas in the remote cardiac rehabilitation, through the application, we do see their compliance levels, and they do actually more exercise. However, like I said, it is a self-discipline. So you do need that self-motivation and the self-discipline to get out and do the exercise. It's not always helpful to have somebody call you and say, you know, you got to do the exercise if you don't have that self-discipline to actually get out. So there are some people that will benefit more in a cardiac inpatient because it makes them come and get out of the house and come to the program, and it you know, so that they're more compliant in that respect. We had not too many. We had one patient that I can think of that started out in the cardiac rehabilitation program, and like I said, it didn't help that we kept calling her and every week she just wasn't there, and she switched over to come into the inpatient program. But for the most part,
where do you think the future of this is going to be? Do you think it's going to be hybrid, or do you think that there's going to be groups that are in remote versus in person?
Right. So we're trying to get it that it will be. I think there's always going to be a group of people that will benefit and will still come to an inpatient cardiac program. But I think that the future is remote cardiac. We're now doing also studies on patients of higher risk, and to see if those are compliant, and see how they can do, and see if they are able to also do a remote cardiac program as well. So we do have those studies going on at this point, and you know, hopefully we'll see that will be good as well.
And I think, you know, just from what we learned from our earlier presenters, I think it would be interesting to see how remote cardiac rehab could become more efficient, you know, using like the AI approaches that John Pate presented.
Absolutely, that was very interesting.
Or even like enhancing the experience the way that Naomi presented on using augmented reality for that. So I think lots of opportunities. Would be great. You guys should talk in terms of enhancing the program. So we'll move forward with the next speaker. Georgiana is going to talk about telehealth and pediatric care during COVID-19 pandemic, parental perspectives, and she's coming from University of Michigan. Georgiana, you have the floor.
Hello, everybody. Thank you for being here. Let me just make the presentation on full screen. Let's see, how do I do that?
You can hit F5.
Oh, thank you.
Either press slideshow or the bottom corner on the right. A little bit to the right. 2 more to the right, 1 more to the right. There you go.
Thank you so much.
Sure. You just need to press it. Just press it and then it'll go into a...
Okay, I have had problems making it full screen before, so I may just present it the way it was. It's restarting now, or PowerPoint is restarting. So just a moment, I'm sorry.
Sure, no problem, Georgiana. Yeah, I think presenting it in the slide mode is okay too. No problem at all. So as Georgiana is getting loaded up, I'll see if anyone, you know, we're kind of cutting it close in terms of time as a presentation, so we won't have much at the end. But I'm wondering if anyone in the audience has any specific questions for any of the presenters that have already presented. or for myself or for SD. And then Georgiana, as soon as you're ready to go, just let us know. Abraham, you have a question?
Yeah, first, great presentation. Go blue. My two daughters went to Ann Arbor, so my admiration. Quick question. One of the challenges with telemedicine is the shortage of specialists, whether it's dermatologists, et cetera, neurologists who specialize in Parkinson, et cetera. So how do you address it? Because the fear is that it will put extra load on those professionals. So what's the University of Michigan approach there? How do you allocate those specialist time between telemedicine and office visits?
Yeah, and that's a great question. Certainly something that involves higher level strategy. I mean, essentially, the way that our specialists have been using telemedicine has been a substitute for in-person care. So we haven't necessarily, for those particular specialists where there's greater need, we haven't necessarily changed anything in their practice. They've just adopted it. Kept the grids the same, but essentially you'll have virtual care days and then in-person days. And that's kind of been the main model. I think in the last couple of years, it's really been mostly about providing telemedicine care for our established patients, so patients that are part of the health system already, as opposed to seeking out care or providing care in areas that are that are more of like a strategic approach. So it really has been more of that than anything so far. But I think it's a huge opportunity moving forward, making sure that those specialists can reach those areas, particularly in rural Michigan where that type of care is needed. Georgiana, you think you're ready to go?
Yes, can you hear me well?
Yeah, we could hear you great. All right.
Yes, thank you for being here and thank you for this opportunity. Today, I will be presenting on telehealth in pediatric care. Specifically, we performed interviews and surveys with parents to find out their satisfaction with telehealth and what suggestions they have for improving telehealth. I serve as an associate professor in the College of Health Sciences at the University of Michigan, Flint. The Flint campus is approximately 1 hour north of the Ann Arbor campus. As you know, and as you have already mentioned, there are various benefits of telehealth, and those benefits also exist for the parent and the child. Telehealth can help with saving cost and time for travel, fewer work and school days missed, receipt of needed care instead of foregoing treatment. This third point here is especially important for children with chronic health conditions who may have multiple appointments, and telehealth could help them greatly improve their health. Telehealth can also lead to decreased transmission of the virus and ultimately improved health of the child. Given these advantages of telehealth for the parent and child, we investigated challenges and recommended strategies for promoting telehealth during the COVID-19 pandemic. We conducted a qualitative study between August 20th and May 2021. And we conducted an online survey where there were 105 respondents and a virtual interview with 24 respondents in Genesee County. We recruited these participants at pediatricians' offices, farmers market, and the University of Michigan, Flint. And participants had to be caregivers of at least one child under the age of 18. Just to tell you a little bit about Genesee County, the county has higher poverty rate than the state of Michigan in general. Our international colleagues may have heard of the Flint, Michigan water crisis, where the water became contaminated due to, so the water became contaminated with lead due to insufficient treatment. And so generally in Genesee County, and particularly in Flint, which is part of Genesee County, research has found that there is higher poverty and also more distrust towards institutions. We recruited participants through flyers and email invitations. We also collaborated with pediatricians to be able to recruit patients. We would go to the pediatricians' offices and ask pediatricians if they could allow us to recruit in the waiting room. As I mentioned, this is a qualitative study, so we asked open-ended questions, such as what challenges with telehealth have you experienced and how would you improve telehealth? For the survey, we used Qualtrics. It was an online survey. For the interviews, those were online interviews, generally through Zoom, but if the person was not comfortable using Zoom, we used telephone. We recorded those interviews, we then transcribed them, we read those transcripts several times, and we developed themes based on the responses. Just to tell you a little bit about participants, their mean age was approximately 36 years old, and they were primarily white Caucasian and African Americans. These are some findings of the interviews in terms of access to care and some representative quotes. For me personally, when it comes to qualitative studies, it is most interesting reading some of the quotes in terms of what people's experiences are. And with qualitative research, we want to look at those deeper experiences and thoughts. In this particular study, actually, we did have many people who mentioned that they have not had telehealth offered to them and that they wish that this service was offered. Caregivers considered switching providers if telehealth was not appropriate, and they were generally more satisfied with care during COVID-19 when they were offered telehealth versus when they were not. There were various challenges to telehealth or to using telehealth, and based on these challenges, we can then think of what interventions we can develop. One of the primary concerns was the lack of in-person interaction, and you see here some representative quotes. Participants, some stated that they received the information better in person, that they wanted to be in the same room with the provider, that they felt better rapport with the provider that way. Some felt that the child was not really very well present during that appointment. And so lack of in-person interaction was one concern. Other concerns here, a possibility for medical error. In addition, some participants stated that they were not sure when to make a telehealth versus a face-to-face appointment. Some participants stated that fear of confidentiality loss was a concern, and the inability to connect for an appointment or to have technical issues during an appointment was a common concern as well. And so I have so far spoken to what parents said in terms of challenges with the use of telehealth. And next, I will talk about what interventions they recommend to promote the use of telehealth or access to telehealth. They first suggest the use of media campaigns so that we spread the word about the benefits of telehealth. And so here, there was the thought that people may not know why telehealth may benefit them or their child. And so education on that would be helpful. Participants suggested more consistency among providers, not only in the same state, but also across state lines. And so you see here one participant stated, pediatricians can practice medicine across state lines so that people can access the best care and they don't have to live right next to or have the money to travel to a really good specialist. They had more suggestions that we need more governmental funding to make telehealth more accessible. And some of you stated that in Israel, there are those computers that people have access to. And I think that this would be a great idea here to offer computers either at libraries or community centers for family and children to be able to use for telehealth. In addition, participants recommended the development of an educational program on the use of telehealth and the benefits. And so it was important to cover both of these things, not only how to use it, but also what the benefits are. And they are suggested to have some brochures also in the pediatrician's office on the use of telehealth. And so some implications of the study is that we need to offer telehealth as an option to all patients and parents. And the telehealth is especially important for parents of children with multiple chronic health conditions. And that we do need to think about how to make that video visit more personal, how the person can feel comfortable during that visit. And that we need to accommodate people with different technology levels. We need to create more trust towards that electronic sharing of information. We recommend, based on these findings, educational interventions on the use and benefits of telehealth. And these interventions may assess the effectiveness of telehealth on various outcomes, such as effective communication between the patient or the parent and the physician, on reducing medical errors, on improving health outcomes, and reducing COVID-19 transmission. With this, I would like to thank you again and to say that, this was a small pilot study supported by an internal grant by the College of Health Sciences.
Jana, thank you so much for that interesting study. I have a question. Maybe you know, was there a study conducted to try to understand the concerns of physicians about telehealth? And you know, maybe they had shared concerns like the parents, because I heard themes that I heard from physicians in Israel, and I'm wondering whether physicians in the United States have them as well.
Yes, and actually one of the reasons that we conducted this study is because there has been more research on the concerns of physicians rather than parents. But yes, there have been studies. I can think of one large study where actually providers talked about challenges to the use of telehealth. And one of the challenges was that parents were not knowledgeable regarding its use. I myself actually conducted a study where we interviewed pediatricians by going to their offices. And so again, one of the suggestions was to also intervene not only on the provider side, but on the parent side. And again, this is how this study got started.
I see. Now, the telehealth is conducted through which modality? I mean, it's through video calls, or I mean, Zoom, or is it something else? I mean, in Israel, we have something called Taito, where you can examine the child remotely and send to the physician. Is that something too sophisticated, or what do you have there?
In terms of the University of Michigan, and I am a patient there, we have a portal, and we can have appointments, we can have a Zoom video call, we can have a telephone visit. In the area where I conducted the study in Genesee County, actually telehealth is not all that common. And actually when patients request a telehealth appointment, some of the providers may be surprised and they may offer them one, but they may offer it one through a phone call. But the University of Michigan Ann Arbor has a very sophisticated system for video visits.
Georgiana, again, thank you so much. Chad?
Thank you.
Great. Thank you so much for sharing that work. So just have just a couple closing remarks. First, where I want to just thank everyone that participated in this. Particularly, I want to give special thanks to the Israel telemedicine community for reaching out and really helping to create this collaboration, which I think was great. I want to thank all the presenters that took the time, relatively short notice, to put together their talks. They were all very engaging, all different specialties, all different fields, but you can see that there's a lot of common themes, and and challenges that both of our countries are going through. And we're learning a lot from everyone that presented. And I look forward to hearing updates from everyone. Also want to just thank Ron for being a great co-moderator to help keep the conversation going.
Thank you, Chad. It was a pleasure.
And then also just want to give special thanks to the IHPI staff like Emma and Stacy who helped. It seems like putting together a Zoom meeting like this is simple, but in reality, there's so many moving parts. So thanks a lot for keeping everything moving smoothly. And then finally, I just want to sort of end with, moving forward. And I think number one, if there's any questions or if you want to reach out to any of the presenters, Ran and Emma's contact information is listed on the screen. Feel free to contact us. We can be great point people to help make that connection. And then also we are starting to think about what do we want to have with this collaboration moving forward. And I think at bare minimum, presentations like this on an annual basis would be fantastic. I think the other thing that we've talked about is having a listserv so that when there are updates from the presenters or from other achievements within this community, they can be sent out to others so that we can learn from each other, share lessons, and reach out and collaborate with each other. So when you registered, if you left your email, we'll certainly use that to create that listserv. But I think that if you didn't leave your email, and you can reach out to us and we can include you there. So and then I think in the future we could also reach out for other types of collaborative experiences too. But those two things I think would be the bare minimum. And so Esti, wanted to see if you had any final thoughts or anyone from the Israeli telemedicine community.
Just to say thank you very, very much. I really enjoyed, and thank you all the presenters, because I think it was really, really interesting to hear the similarities and the differences between both countries, and looking forward to further collaboration. Thank you.
Thanks so much. And we'll make the recording of the presentations available. Emma will reach out to with that information too. So,
thank you and shalom.
thank you. Take care.
Thank you very much.
Yeah.